Bismillahirrahmanirrahim. Good evening and good afternoon, ladies and gentlemen. It's my pleasure to be here with you in the Arab Thyroid Association. Thank you, Dr. Am, for inviting me, and thank you for the organizing committee. As Dr. Am mentioned, I'm endocrinologist, not interventional radiologist, but I will tell you why I'm interested in the field of thyroid interventions. Actually, I added to my title that the thyroid thermal ablation made a paradigm shift in the thyroid nodules management, actually, and this is well established in a lot of practices. I come from Mansoura city. It is about 70 kilometers to the north of Cairo. This is my hospital and my university. I'm a professor of medicine, and I'm interested in the field of diabetes and endocrinology, especially the thyroid interventions. In my agenda with you today, I will discuss the following points. Number one, what is the introduction and the epidemiology of thyroid nodules? And I will give you studies that conducted by us in Egypt. And I will give a small hint about the chemical ablation for the thyroid nodules, which is including the ethanol and other chemicals. Then, what is the thyroid thermal ablation? What is the advantage in comparison to surgery? What is the indications and what is the contraindications for the thyroid thermal ablation? Then I will give you a small hint about the clinical evidence and positions in the guidelines. Then finally, the summary and the take-home message of my presentation. Thyroid nodules is any abnormal growth that make a lump in the thyroid gland. All of us know that it could be presented clinically if the patient, for example, notices any swelling in his neck or having symptoms of hyper or hypothyroidism, or it could be present incidentally. All of us in the era of COVID noticed a lot of patients that made CT chest for chest problem, then incidentally found that there is a thyroid nodule. Regarding pituitary, regarding adrenal, there is a different clinical scenario in the management of incidentally found mass or clinically found mass. But this does not exist in thyroid. Thyroid nodule, either clinically or incidentally found, it carries the same scenario and same management. The prevalence from the US coming studies suggests that it is clinically found maybe in about 7% and radiologically found maybe about 3/4 of the population in the USA have thyroid nodules by the ultrasound. We heard today in the early afternoon that it is increase in females and increase with age. In Egypt, we conducted a study and we found that about 1/5 of the Egyptian population, which is having, we made for them ultrasound, is having thyroid nodules. And it is about double in the patient with type 2 diabetes in comparison with those without type 2 diabetes. Till few years ago, any goiter which is having compressive or cosmetic problems, there is no treatment apart from the surgery. Alhamdulillah, that majority of thyroid nodules are benign. More than 95% of thyroid nodules are benign. And even those with thyroid malignancies having a great prognosis. Also, a lot of management options are available for thyroid nodules. The classic and the gold standard one is the surgical resection. And to my opinion now, it is the best for the huge retrosternal goiter, for those patients with malignancies or suspicious of malignancies, for those with refractory Graves' disease with a contraindication of radioactive iodine or unavailable or safety issues, and for those with benign options or for those with the toxic adenomas, there is another option. The another option, which is the radioactive iodine ablation, which is a great option, especially for the toxic adenomas or the toxic multinodular goiter. But also it is not available in all countries. Environmental safety is an issue, and sometimes it carries the risk of hypothyroidism and the need for lifelong treatment. We have the chemical ablation. The classic gold standard chemical ablation is the ethanol ablation, in which it is in a cystic or a mainly cystic nodule that we aspirate the fluid, then we inject the ethanol. But there is some studies about the injection of the bleomycin, which is a chemotherapy, the tetracycline, which is an antibiotic, and also I'll discuss with you our experience with the polydecanol, which is a sclerosing substance. and the main object of our lecture, which is the thermal ablation. We have a 4 worldwide thermal ablation method, which is the radio frequency ablation, microwave ablation, laser ablation. I have experience with those 3, and I don't have experience with the HIFU, which is the high intensity focused ultrasound. When we see this picture in the ultrasound, we always happy because we don't need any fine needle, maybe 0 risk of malignancy, and most of those cases are benign hemorrhagic. They are not suspicious. We don't need to do any interventions except if there is cosmetic or compressive issue. This is an example of one of my patients. If you aspirate this 40 cc of hemorrhagic fluid and inject alcohol, everything will be great. The patient may need 1 or 2 another sessions, and you dissolve his problem without any need for surgery, just in a 10 minutes procedure under local anesthesia. But if any one of you tried alcohol ablation, it is mostly very painful on the cases. Sometimes if you inject a lot of alcohol, it leads to flushing, hypotension, headache, pain, some hoarseness of voice, especially in those cases near to the recurrent laryngeal nerve. So we conducted and published the data about injection of polydecanol. Polydecanol is a famous substance with our colleagues in the vascular surgery. They inject it to sclerose the varicose vein. It itself, in the ampoule of the polydecanol, it has a local anesthesia, and it is nearly painless. We conducted this study and we found that all results are comparable, with advantage that injection of the polydecanol is associated with a nearly painless procedure. And the main problem that those, as in this is a foreign substances, not like the alcohol, but those with polydecanol develop usually fever in the first week. So this is, we notice this because this is like another foreign substance. It is very, very common to be noticed, but all of us should be aware about this. The fever which is developed, it is not due to infection, it is just for the sclerosing substance. Let's go for the thyroid thermal ablation. When you are in the medical school, we heard about the thermal ablation the first time, I think, with the hepatocellular carcinoma. What is the difference between the thermal ablation, for example, in thyroid and other tumors like hepatocellular carcinoma or osteosarcoma or lung cancer? The main thing that in thyroid we are dealing till now with a majority of cases of ablation in a benign lesion. It is just like a cosmetic procedure. When you are dealing with a benign lesion, most of insurance system in Egypt, I don't know how is the system here in Gulf, but in most of insurance system in Egypt reject to cover this procedure because they consider it as an cosmetic procedure. In thyroid, we are not aiming in benign lesion, we are not aiming to distract all the lesion. We just want to shrink the lesion to make sure that the problem of the patient is improved. But in the cancers, we want to distract all the lesion and have another safety margin outside the lesion to make sure that we are removing a cancer. If you look for me, this is, for example, a thyroid nodule. When you are doing ablation, we just aim to shrink the nodule, not disappear it. And this is carry the risk for recurrence or regrowth after few years. But for example, if you are dealing with a hepatocellular carcinoma, we are doing ablation and we should have a safety margin outside the lesion to make sure that we are distracting all the malignancy. And this is the main difference between the thyroid thermal ablation for the benign lesions other than the malignant lesions. When I'm giving lectures about the thyroid thermal ablation in most of conferences, especially with my colleagues in radiology and surgery, all of them told me why you are here, why you are not sitting in your office and just prescribing carbimazole and thyroxine. The message, and thanks to Allah, because of this case. This case, which is the trigger for me to learn thermal ablation. Huda is a 29 years old single lady, started to develop the classic toxic symptoms of the hyperthyroidism. But the main problem that her wedding, she will marry after 3 months. She come with her mother. By examination, she's carrying the classic symptoms, which is making us suspicious of hyperthyroidism. And by the neck examination, there is an asymmetrical neck swelling. In our office, if we see a diffuse thyroid goiter, usually we are feeling comfortable. But if you see an asymmetrical goiter, you feel somewhat worried. When we ordered the thyroid function test for her, we noticed that there is a suppressed TSH with elevated free thyroid hormones. And when we did an ultrasound, she's having a left solitary thyroid nodule, ACR thyroid 3 classification. According to the guidelines, we did thyroid scan, and it shows us that this is a hot nodule. So all of us say, Alhamdulillah, this is mostly 98% is benign. So we offered the following for the mother. We told her that one of the options is to do lobectomy and do the surgery. The mother and the girl screamed, "You want to cut my neck? You want to make me a scar? I will marry after 3 months. Forget the surgery." There is another option, which is the radioactive iodine, but we told her that you should either postpone your wedding or taking a contraception, because all of us know that we should, after radioactive iodine, at least postpone the fertility for 6 months. Again, the mother, like the Egyptian mothers, and I think all the mothers, told me, we don't want to let her husband or the relatives know, forget this option. The marriage will be in the same date. So we decided to make a medical treatment till she gets pregnant, and after that, we will find another solution. So we commenced here for the carbimazole and propranolol. Just a few days after that, the patient developed an attack of nausea, vomiting, itching, and yellowish discoloration of her eyes. CBC were normal, shooting liver enzymes, pattern of hepatocellular jaundice, other routine investigations were normal, so this is mostly an toxic or drug-induced hepatitis. What to do if you were me? The mother is refusing surgery, and they are refusing radioactive iodine. And what to do? Will you shift her to the propiothyroxine, which is known to be more hepatotoxic, or keep it on carbimazole, or what you do? So I searched in the literature, and I read about the radiofrequency ablation, and I sent the patient for the ablation, and the toxic adenoma was resolved, and the patient was cured. So the thyroid thermal ablation carries a lot of advantage in comparison to surgery. Number one, if you are dealing with a cosmetic problem, it is not logic to remove a mass in the neck by making or leaving a scar. This is not logic. Now we have actually our colleagues in surgery are doing laparoscopic lobectomy through the axilla or through the suprasternal notch. But one of the important issues that you are treating a patient problem without leaving any scar. For me as an endocrinologist, before I'm interventional thyroidologist, I hate to treat 2 diseases in my clinic. The first disease is the post-thyroidectomy hypoparathyroidism, and the second disease is the diabetic neuropathy. I hate to treat these two diseases because usually there is no cure. The patient claims to you and usually is not improving, so this is not happen. Hypoparathyroidism is not happen when you are doing ablation. There is no need for lifelong replacement therapy. There is no improvement in the quality of life. There is no need for general anesthesia because it's completely done under local anesthesia. There is no need for hospital stay. It is a short time procedure, less than 1 hour, and in a comparison to surgery, if you did it well, it is a very, 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 very minimal complications. What is the indication? Number one, it is a benign, non-functioning thyroid nodules, which is causing compressive or cosmetic problems. Number two, if it is a toxic adenoma, but the mean volume is less than 12 milli, if there is a malignant nodules and the thyroid microcarcinoma less than 1 centimeter. When I started to study and read in depth about this indication, I scratched my head. The least diameter to take FNA from it is 1 centimeter. All of us, even if it is a thyroid 5, the least diameter to take a fine needle from a thyroid nodule is 1 centimeter. Below 1 centimeter, you just do follow-up. So how you will diagnose a thyroid microcarcinoma in a patient and the maximum diameter of the nodule is less than 1 centimeter? This data actually come from China and South Korea. Because in China and South Korea, it is obligatory to do annual screening by ultrasound for all the Chinese population. And if there is a suspicious nodule, even if it is less than 1 centimeter, you take a fine needle and you diagnose a microcarcinoma. All of us know that one of the line of treatment is the active surveillance. Imagine with me that you're telling the patient, my patient, you have a thyroid cancer, but I will do nothing for you. I'll just follow up to you every 1 year. A lot of patients actually hate this and feel anxious and afraid. One of the options is to make ablation for them, and this is approved in a lot of Chinese and South Korean guidelines, and recently the European guidelines. And also, one of the cases is the lymph node, which is appeared after surgery in the surveillance in the post-thyroidectomy, to avoid redo of the surgery, which will be difficult and carry some complications. You can do ablation if it is a single, visible, and easy accessible without injuring of the surrounding structures. It is not my issue here to discuss the details of the procedure, but simply we do an ultrasound local injection of the anesthesia, then we enter the needle, then we do ablation, but to make sure that the temperature is not distracting the surrounding dangerous triangle, we surround the thyroid nodule by a water. We call this hydrodissection. Then after that, we make sure that all the vascularity in the ablated area is disappeared. So this is mostly successful ablation. Before ablation, we should discuss with the patient the procedure, and we should discuss with him that it is not a cure for the nodule. We are shrinking the nodule up to 70 to 90% in a cystic or a mainly cystic nodules. We should take at least 2 fine needle or 1 true cut biopsy to make sure it is benign. It is a patient with anticoagulation should be stopped at least 5 to 7 days, and those with antiplatelet should be stopped 3 to 5 days before the procedure. If there is any uncorrectable coagulation deficit, or the patient could not stop the anticoagulation, it is a contraindication for this procedure. If it is Bethesda 3 or more, or suspicious of malignancies, or even if it is a benign FNA, but very suspicious ultrasound, it is also contraindication for this procedure. Because as I will discuss with you, once you put the needle and burn the nodule, the picture in the ultrasound completely looks like a malignant. So if there is a problem, you are doing miserable things. You are not know, is this is the look for the ablation or this is for malignant transformation. How to do a safe ablation? From my experience, if you did this 3 points, inshallah, nothing will happen and no complication will happen. Remember that the safety is the main and first line, then the efficacy, because you are dealing with a nearly, in most of cases, cosmetic procedure. So the safety is the main issue. Those 3 gold standards, I usually teach it to my students. Number 1, to do good hydrodissection. The more hydrodissection and injecting fluid or saline surrounding the thyroid nodules, devoiding it from the dangerous triangle, inshallah, nothing will happen. You should have a good visualization. Never to burn except you are seeing the tip of the antenna. Otherwise, you may injure a very important structures. And we use the moving shots technique, in which we start from the posteromedial part, from the lower part, then moving shots to burn the thyroid nodules. Also, if the nodule is either large and have some retrostent extension, we can use what's called the iceberg technique. This is one of my patients which is completely refusing the surgery with about 12 centimeter length of the thyroid nodule. She's completely refusing the surgery. After 1 year, the cervical part was disappeared and the part in the sternum, retrosternal, become shrunken. So if you do another session, it will be great for the patient. The patient is just wait for 1 hour for observation and take some anti-inflammatory and prophylactic and steroidal, and everything is well for the patient. This is my card. I give it to the patient for the follow-up, but I want to insist again and again for this paragraph. Because if you see a patient with an ablation, if you are a radiologist and if you don't know the history, a lot of my patients, when I start my career in ablation, want to kill me, because if they are doing ultrasound, they did for the radiologist, told, oh, you have a thyroid 5 nodule, you have a cancer in the thyroid. All of the suspicious criteria apart from the lymph node, all of the suspicious criteria are present. So you should learn the patient that this is a post-ablation image, don't be worried and everything will be okay. Also, I follow up for the patient, the Hamilton Anxiety Score is completely improved and the quality of life is improved. Excuse me if I have 1 or 2 minutes, please, to finish my lecture. Those are the complications. If the complications is, if you did a great hydrodissection, if you did a great visualization of the needle, everything will be okay, and inshallah, no complication or no major complication will appear. When you open the literature, PubMed, ResearchGate, whatever your machine, you'll find a lot of paper. This is the summary, a lot of guidelines, a lot of guidelines, a lot of guidelines. From more than 10 years, there is all these guidelines recommend and insist on the efficacy of the thyroid thermal ablation. Finally, the European, in Egypt, we don't like the guidelines which is coming from the East. But we have a, I don't know why, but we call it, I don't know how to say in English. You say it in Arabic, عودة الخواجة. We don't like, usually, we have the عودة الخواجة. We like the guidelines from the European and USA. So for this, after the European guidelines, they are published to make sure that it is a present and it is established. And also, they did the guidelines for the ablation for the microcarcinoma. All of us know that in British guidelines, it is difficult to enroll any procedure. Again, the British guidelines and the Oxford started to put it in the guidelines. Mr. Chairman, dear colleagues, let me end my presentation by this message for Gandhi. First, they ignore you, then they laugh at you, then they fight you, then you win of them. For those who want to start or to want to refer, this is my advice for you. Be professional for the ultrasound. Do at least 50 fine needle to be successfully. Start with a phenol ablation. Start ablation with under supervision, then select easy cases. This is my last slide. This is the best case to start ablation with it. Those with a purely cystic or mixed solid or spongy form or solid without any vascularity or with any out calcification, you will have a great results. Thank you again for inviting me here, and happy to hear any questions. Thank you.